Well, good afternoon, everyone. Welcome to today's webinar presented by Maimonides Medical Center, Central Services Organization, and the Brooklyn Health Home, and GSI Health. A bit of housekeeping as we begin our session this afternoon. You've all been placed on mute through the webinar. However, you can participate in the dialogue by offering questions on the right-hand side of the navigation toolbar, the third or second item from the bottom, by inserting questions there. We'll collate these, and then at the end of our presentation, we'll address them with our presenters this morning. We also ask that if you have any need for any other items, not use the chat, try and use the questions as much as possible. Also, as an attendee of today's event, you'll receive a link to the webinar as we're recording it today after October 26th. Lee, if we could advance to the next slide, please. So I'd like to introduce our speakers today. We have three that have joined us to present. Our first is Sarah Kaplan-Levinson. Sarah Kaplan-Levinson is the Executive Director of the Brooklyn Health Home. In this role, as part of the Maimonides Central Services Organization, or CSO, supporting population health, Sarah is responsible for the administration of the health home and also provides support on care management initiatives related to DSRIP, Delivery System Reform Incentive Payment Program, and other population health activities. Prior to joining Maimonides in 2014, Sarah worked at the Greater New York Hospital Association in the Department of Legal and Regulatory and Professional Affairs, where she covered issues related to health information technology and patient safety from a policy, advocacy, and operational perspective. Sarah holds master's degrees in public health and social work from Columbia University. Also speaking today is Michael Carberry. Michael Carberry is Chief Information Officer for Population Health for the Maimonides Central Services Organization. Michael serves in dual roles as the leader of the global information technology effort for Maimonides Performing Provider System, or PPS, in the New York DSRIP program, known as Community Care of Brooklyn, and as Chief Information Officer of the Brooklyn Health Home. In these roles, Michael leads the continuing development and implementation of the CSO, providing community-wide care coordination, communication, and analytics systems from GSI Health. He promotes the expansion of electronic health information exchange with Healthix, the Regional Health Information Exchange, and the Statewide Health Information Network for New York, or SHINY, and directs the implementation and support of other centralized technology services critical to the success of population health programs throughout the Maimonides-led PPS and Health Home. Previously, Michael directed the technical efforts for the Maimonides-led New York State HEAL 10 and 17 grant programs, the Brooklyn Health Home, and the Maimonides CMMI HCIA grant program. Michael has significant experience in managing complex and time-sensitive health information technology initiatives for healthcare providers, as well as serving as information technology and business operator roles in other industries. Michael is a 1979 graduate of Princeton University. Our final speaker today is Lee Jones. Lee Jones is Chief Executive Officer of GSI Health, a healthcare technology and solution company that provides integrated care coordination and analytics enabling whole person care for complex populations. GSI Health is on the forefront of population health management solutions and has helped pioneer working models for effective collaboration in community-based care delivery. Lee is a recognized expert in healthcare information exchange and health IT more broadly, performing strategy development, business analysis, technical architecture, and solution design. He has assisted several states in the development of architectures and operational models for health information exchange. Lee holds a Master's of Science in Engineering in the Management of Technology jointly from the Wharton School and the School of Engineering and Applied Science at the University of Pennsylvania, and a Bachelor of Science in Computer Science from Carnegie Mellon University. Today our session is going to be divided primarily into two sections. The first is creating a community-based network for value-based programs and will be provided by Sarah Kaplan-Levinson and Michael Carberry. Our second session, community-based population management approaches, will be provided by Lee Jones. Throughout today's session, we'll continue to collate questions in the questions box to the right of your screen in the navigation panel, and we'll address those questions with answers from our panel at the conclusion of our session. At this time, I'd like to hand our presentation duties over to Sarah Kaplan-Levinson and Michael Carberry from Maimonides CSO and the Brooklyn Health Home.
Thank you for that introduction, Sean, and good afternoon, everyone. Very happy to be here presenting on this topic. I guess we can go ahead to the first slide, Lee, or the next slide. And we're gonna tell the story of our creation of our community-based network, which has supported an evolving set of programs for the last decade. So I think that, you know, when you look at this slide and we go ahead and talk about our current activities, the most important takeaway is really that this has been a very long journey. It takes a long time. It takes a lot of investment and effort from partners to make something like this work and to make something like this be nimble and flexible enough to really evolve with changing healthcare environment and landscape and the ever advancing new programs with their varying requirements, all in support of the same goals of advancing population health. So this really represents our journey beginning in 2005 with the Brooklyn Health Information Exchange, an early effort in health IT-enabled information sharing. And that really has evolved over the past decade through multiple iterations of care management, investments in the technology and enhancements to the technology, and then bringing in different community-based providers, collaborators, clinicians to really build the workforce that makes up our network. So we moved through a variety of programs that really focused on care coordination and collaboration in the behavioral health population, beginning with a physical co-location of services in primary care and behavioral health, and moving from there to realize that there's a lot more opportunity in the virtual coordination. And so that's when we moved into our two HEAL programs, HEAL 10 and 17, the mental health home model, in which the patient, the individual, is really at the center of their care and surrounded by their care manager and that care management team, and then that team is supported by the technology infrastructure that we use, which we'll describe a little bit later, which allows them to communicate with anyone else, any primary care providers, psychiatrists, ancillary service providers, housing providers, folks in the criminal justice system that might be touching that individual and need to participate in their care planning or care delivery. That program really set us up very well to become designated as a health home when the health home program launched in 2011. It's a little bit of an expanded model of the mental health home because it also includes individuals with chronic medical conditions, multiple chronic medical conditions, and HIV or AIDS. And of course, we've seen that there's a lot of overlap in chronic medical conditions, behavioral health conditions, substance use, and social vulnerabilities. So the health home gave us the opportunity to make sure that our network of providers really addressed all of those issues and had the capacity to treat, you know, sort of any presenting need of our target population, that we had those resources available. We were then fortunate enough to receive a grant from the Centers for Medicare and Medicaid Innovation, and that really allowed us to expand the model, invest very heavily in workforce development and training, and expand our HIT platform to facilitate all of that virtual communication and collaboration. And that foundation has advanced into the even broader delivery system reform incentive payment program, DSRIP, which we expanded our network. You'll see on a future slide from about 50 organizations to well over 800 to serve the entire, or a very very large portion of the entire Medicaid population of Brooklyn. So that's a bit of our history, and I think, just as I mentioned at the outset, underlines the fact that this is not something that can come together overnight, and nor is it something that can or should be static, and definitely continues to evolve and improve over time. We can go to the next slide. Okay. So I just wanted to talk a little bit about how our current activities really mutually enhance and support one another. Our main programmatic efforts right now are the Health Home and the district PPS. So we really start with this core belief that health homes and the care management they provide are a cornerstone of district activities. That's the foundation that's really going to lead to and support the transformation of the delivery system from volume-based to value-based. And so rather than, I think we try to always approach things with the philosophy of, okay, it's not another project, another layer of reporting requirements, or, something else that we're adding to the mix, but how are we able to continue to enhance our overall efforts in delivery system reform and population health through the variety of funding streams and network building opportunities available to us. So we looked at this as a real opportunity and tried to leverage the systems that we had already built. And I think a couple of these we can really highlight here. First of all, and I think this is somewhat unique at this moment amongst health homes and district PPSs, is that we are utilizing, the Brooklyn Health Home and the Community Care Brooklyn PPS are utilizing the same web-based care coordination and population management platform. So all of that investment that's gone into building that infrastructure, from the mental health home through the HEAL grants, through CMMI and the health home, is now being scaled to support the entire district effort. And many of our community-based partners have already been operating in that system for some years now, so it's an opportunity to really spread that training and education and bring even more folks into that environment where they can work together regarding the care of individuals and communities. Then DISRIP, our PPS, has the attention of hospitals and clinical providers in the community in a way that health homes have, I think, struggled to achieve. So the health home really has an opportunity to benefit from that wider knowledge of the program and buy-in at both a leadership and a frontline level to facilitate more meaningful collaboration. So the health home has always had an imperative for care managers, primary care providers, hospitals, psychiatrists to work together, but there were still sometimes those walls and silos and barriers that were hard to break down, and we'll talk a little bit about how we've done that and continue to do that so that there's an actual meaningful interaction happening between a non-clinical care manager and a clinical provider in the community. And sometimes that even starts at being, let in the front door, knowing what the program is called, what it means, and it takes a lot to actually spread that message. On the other hand, whereas DISRIP really did capture the attention of the clinical world, the health home had already made great inroads into the community and the community-based organizations, the social service agencies, and other providers, and have a very well-established network. And I think for PPSs that maybe didn't have that, or weren't building off of a health home, or hadn't really cemented that relationship with the health homes in their network, it's a little bit more like starting from square one, trying to identify the resources throughout the community, get to know them, help them get to know one another, and build that relationship. So there's a lot to leverage there in terms of those partnerships to meet the broader goals of DISRIP. And I think along those same lines, the health home has a number of standards and protocols for community-based care coordination that have proven very successful over the past 5 years. And so we're able to translate those tools into use in the PPS in activities like care coordination and care transitions that we'll talk about in a bit more detail as we move through the presentation. Next slide. So this is just a little snapshot of our networks. So you can see we began with the Brooklyn Health Home Network, where we have 23 agencies, care management agencies, that are actually providing the direct care coordination services, where our approximately 9,000 health home members have their care management node. But we also have relationships with medical providers, housing providers, behavioral health providers and substance use providers, social support services, and criminal justice services. So we're able to share data, share resources, connect individuals to care in a very timely fashion through those relationships. Through our PPS, the Community Care of Brooklyn Network, we've expanded that network dramatically. So everyone who's in the Brooklyn Health Home Network, by virtue of the Brooklyn Health Home being in the PPS, is also in the CCB network. But to take care of upwards of 500,000 attributed Medicaid beneficiaries, we needed to grow and include folks from all over the borough. So we have over 4,500 practitioners, including 1,600 primary care providers, and then over 800 other participant organizations, including 6 hospitals, which you can see noted off to the right, lower right-hand corner, 10 federally qualified health centers, 3 independent practice associations, and then again, much like the Brooklyn Health Home Network, a broader spectrum of behavioral health, social service providers, CBOs, other health homes as well, and advocacy organizations and home care. So it really is a very interesting process, sort of bringing all those folks to the table, developing committees and the structure to actually define these programs and make sure that everyone's perspective of the full picture, the comprehensive care of what these communities need is represented. And I think it results in a very robust approach to population-based public health and care management. Next slide. So when we think about building a network, really, what are our goals? So as I was just beginning to reference, we need a network of health and social service providers that are sufficient to address the needs of the target population. So one of those things is the scope of services. Do we have the right types of substance use providers, the right types of chronic disease management expertise, housing, other social services for benefits like having to do with food insecurity or utilities and things like that that are really the struggles facing a lot of this population that they feel, and I think evidence shows, have to be addressed, if not before, then right alongside those health problems in order to attain and maintain any level of stability and wellness. So there's the scope of services to be considered, but also the availability of those services. Are there neighborhoods and communities that aren't served by the right mix of providers? Are there other considerations that we want to think about, either bringing in providers or helping providers share resources to provide services beyond the 9 to 5 window and on Saturdays and Sundays and things like that, because we know that's when folks tend to end up in emergency rooms or needing an emergency shelter bed or possibly getting picked up by the police and ending up in those settings that are very expensive, that are not good for people, like jails, shelters, emergency rooms, and further interfering in their continuity of care and their stability. And then how does that network and the goal of the network of those providers focus on achieving the triple aim? So improved quality and lower costs, and also an improved experience of care on the part of the individual. And I think one of the overarching goals, too, of establishing a network like this is to really prove the point that in this environment for nonprofits to succeed, these social service agencies, the CBOs, but also for clinical providers and hospitals, and as we're moving into the value-based models of care, and especially these mission-driven organizations, collaboration replacing competition will really be the key to success and sustainability and longevity of those organizations, in addition to the excuse me, achievement of their missions. Oh, excuse me. So I think what we'll talk through as we go through the rest of the slides are some key considerations and activities that we've invested in. Excuse my choking. To make all of this work. So as I was talking about, we consider the provider types. Who do we need to bring into this network? There are the obvious players, and then there have been some less obvious players. For example, organizations that provide home-delivered meals may not be the first place you think of when you're building a network like this, but actually is a tremendously important player to have at the table. Faith-based communities, neighborhood organizations, bodegas, things like that. So who do we want to be part of our network, and who do we want that network to also continue engaging on the outside? So building those provider profiles and then bringing those providers, and we've done this a lot via the Health Home, into the meetings that we hold, so that folks can actually learn about one another, get information about eligibility for services, how to refer, actually form personal relationships, right? So there's a key component of all of this is our technology-enabled communication, but that doesn't sort of eliminate or obviate the need for those personal connections. So we do have a really robust committee structure. I can talk, I'll go into a little bit of detail about the Health Home Committee structure, where we have a business operations and HIT committee, we have a clinical committee, we have a care manager workflow committee, and a justice-informed workflow committee. So different folks from frontline staff to leadership to folks from billing and finance attend these different meetings and get to share best practices, troubleshoot common challenges, and we actually, especially in the workflow committees, bring providers in, such as a specialty pharmacy, legal action groups for the justice-informed workflow, to really share those resources, get to know people, give out their phone numbers, so when the care manager is calling them up to say, I have this client, I need to make a referral, I need it to be accepted right away, or can you help me find the right resources for this person? They really know that they're calling the right place, and those phone calls are welcome because there's a person-to-person relationship that exists. So I think our committee structure has been very useful for that type of sharing, but also for the development of really consensus-based policies, protocols, and standards of care that everyone from across the network feels some ownership over and invested in, and it comes from the network itself. It's not handed down from the lead agency, and I think that's been a big part of our success as well. Education and training is also absolutely critical. So we have a care coordination training that covers a lot of the information that you might expect would be relevant. So how do you develop a care plan, learning about motivational interviewing, engaging complicated, complex patients in their own care, helping them achieve readiness for change, setting goals, things like that. Education on serious mental illness and chronic health conditions, all of the things that our population may be facing. But I think a key part of the training as well is really how to perform and work as a multidisciplinary team. And we actually have modules in our training that focus on interdisciplinary team building and collaboration, where it's not only the care managers that are going through that training, but it's primary care providers, it's therapists, it's psychiatrists, and we're bringing them together from across the network to engage in learning and role playing and structuring those programs really actively together. And again, creating those real relationships that they can then rely on. Cross-network learning, I think we've more or less covered that. And then the development and deployment of tools and guidance to support that collaboration. So I'll give you a couple of examples. So for our care management providers, we have a policy, a protocol to follow up with individuals after they've been hospitalized, to visit them in the hospital, to help participate in discharge planning, and to make sure they get to see their primary care provider after they're discharged from the hospital if they were hospitalized for a medical reason, or to see their psychiatrist if they were hospitalized for a psychiatric reason. And what we learned in the beginning was that care managers, they're not clinicians, they're not doctors, they're not social workers, they're not nurses. They were showing up because they had to check off a box, but more than anything, they felt awkward. They didn't know how to interact with the clinicians. They didn't know what they were supposed to bring to the table. And I think, to be perfectly blunt, in some ways the feeling was mutual. The providers didn't understand that how talking to the care manager might be worth their time or helpful to this individual, so to their patient. So we spent a lot of time working with folks from all corners of the network to really flesh out that protocol and develop guidelines for what to do very specifically when you're going to see someone in the hospital or you're having a case conference with providers. Some of those activities can be so simple as calling up the PCP and saying, our mutual patient is in the hospital, I'm going to go visit them, what information can I find out for you? Then something really concrete is happening. The care manager is offering something to the provider. They're not asking for something from the provider. And learning how to ask the type of questions or offer the type of information that we know providers are often interested in when we're looking at free utilizers of the healthcare system, or free folks who often get readmitted to the hospital. So do they not understand their medication? Are they being taken care of by a family member at home that just gets overwhelmed and ends up sending them to the ED? Are they, is this someone who tells their doctor all the time, like, yeah, I take my medicine, of course, I'm a good patient, and the care manager knows that, those pill bottles are full, they're all over the house, they're not organized, because they've been there, right? They're that connection that follows people in between all their encounters with the healthcare system. So there's a lot that they can bring to the table. And when we've put it to providers that way, these are the patients that well, I'm giving them this medication, it has to be refrigerated, I know their electricity gets turned off, all the time, or that script's never going to make it into the pharmacy, or, I can tell them these instructions, but they have nowhere to sleep tonight. And we tell them, we have people that can help with that. They're very, very enthusiastic about bringing care management into the picture. So I would say that it's been sort of a slow process, but a very effective process, and we'll talk about some specific examples of that as we move ahead. We can go to the next slide. So again, this is the way in which the care management providers and the clinical providers have been working together in care transition. So transition from an acute care setting, hospitals, back to the community. So all of the 6 hospitals in our PPS are paired with a care management agency. That agency embeds a health home care manager on site. So they actually become an extension of that hospital team. So frontline staff, nurses, social workers who are assessing these patients will proactively identify folks that they think might be eligible for health home services. And we've told them more or less, if you think this is someone who just needs help, refer them to that on person. They'll take care of all the details about, if they're eligible and things like that, and they'll do the enrollment right then and there. So this person is connected. They're not going to get discharged and get sort of lost in the community, slip back through the cracks before they can be connected to not only a health home care manager, but a transitional care team that's more clinical, that's based in the hospital, that will help that health home care manager implement an even more intensive plan for the 30 days post-discharge, so that they're much less likely to get readmitted to the hospital within the first month of getting sent home. So that's been very successful as the hospitals really begin to get to know those care management agencies, rely on them. We've heard stories of hospitals that said, they know the folks that keep coming back, and they just started saying, okay, as soon as this person is back, I'm calling my health home care manager, they're coming in. And we had one patient that had just been, they couldn't solve why she kept coming back to the hospital, and within a couple of weeks of having a health home care manager, they identified that her need was a hospital bed at home. They got that for her, and she hasn't been readmitted to the hospital since, after multiple admissions over the course of a year. So that's been very successful in the hospital setting. We can go to the next slide. So we're also doing this in clinical settings outside of the hospital. FQHCs, federally qualified health centers, emergency departments, primary care, which we'll talk a little bit about on the next slide, I think. But every setting, we're trying to put where patients go, someone that can screen them, that can rapidly enroll them in the health home and initiate those care coordination services for the folks that are the most complex, that do need to be followed between those encounters to make sure that they have connection to primary care, that they're not inappropriately utilizing the emergency room or getting admitted to the hospital. And so the nice thing about that, and especially with the FQHCs and the primary care settings, is that when we have one health home care management agency that covers the patients from a given practice, it works much better in terms of nurturing that relationship than if their patients are sort of randomly assigned, and maybe each care management agency or care manager only has one or two members with a given practice. Those docs might be getting calls all day long from 100 different agencies trying to talk about one patient each. But if they've got one person that's kind of theirs, it's one agency, they can triage, they can huddle, and they're all taking care of the same group of patients. So that's something that's evolved over time. It's been a very successful sort of change in the way that we partner the care management agencies with the primary care providers. We're also continuing to train health home care managers to do other community-based activities, bringing in community-based providers that have particular expertise in that area to do those trainings. And one example is for home-based management of patients with asthma, that their care managers are actually being trained by CBOs to do environmental assessments of the homes to identify triggers and mitigation strategies to reduce asthma exacerbations in the community. Next slide. So finally, the final setting I wanted to talk about is the primary care practice. As I mentioned, it's really about nurturing that relationship between the community-based provider and the practice. So we have health coaches and health home care managers connecting. The health coaches are based at the practice, the health home care managers are based in the community, and they're focused on really making that patient-centered medical home more operational, so truly integrated in terms of bringing behavioral health, palliative care, focus on the whole person into that primary care setting, and having someone sort of monitor what's going on if someone kind of trips a wire to let them know that they're entering a period of complexity, maybe a new diagnosis, maybe something has happened socially in their lives that they might be at higher risk of destabilizing. Then those health coaches and care managers would sort of jump into action, wrap around that individual, and increase the intensity of their engagement with that person for as long as they need. Next slide. So I'm just going to tee up things for Mike here to talk a little bit more about our IT system that really facilitates all of this. I think it shows sort of how we've used technology to help meet the challenges of building a network, and also sort of go beyond some of the more traditional uses of technology that exists within the four walls of an organization or an institution. So the system is web-based. You can access it regardless of the EHR that you use at home, and it really supports data sharing, care coordination, the creation and maintenance of a single unified care plan that everyone can read, everyone can contribute to, and of course performance reporting across the PPS, which is critical for quality improvement and monitoring and evaluation. Mike will walk through some of the technical tools that we've implemented to support the model, and I'll leave that for him. And I think the point that we want to really make is that the way that this has been built and the way we've deployed it throughout our model really transcends a tool that's just a standalone care management tool or a portal to the RIO. But it's something a lot more robust and active in actually maintaining that network and delivering this model of care. So I will turn things over to Mike.
Okay, thanks, Sarah. That's tremendous, and welcome to everyone on the webinar. I just have a couple of slides, a couple of pictures to show you the kind of technical capability we think is necessary. Lee, if you move to the next slide, please, sir. So, again, there's a couple of slides providing a picture of what is the capability necessary to really operate a network like this. And we're going to kind of show you the current state. Of course, it's at all very humble beginnings, and we expect over time for it to become even more sophisticated. There are a lot of pieces to this puzzle. Of course, GSI Health is our big technology partner on the care coordination side and analytics side, and that's most of this slide. But also, we shouldn't forget that Maimonides for a long time has had a leadership role in standing up and forming the RIO, BHIX, which was the Brooklyn Health Information Exchange, now absorbed into HealthX, very, very large New York City area RIO, which is part of the SHANE, the Statewide Health Information Network of New York. So we've had a big role in that, as well as in working with providers themselves to adopt and improve electronic systems, et cetera. So when we talk about the programs we've had and the grants that have been awarded and we've executed and the things we're doing, it's really a sort of a multifaceted effort where, jointly with our partners, with the state, and sometimes with national resources, we're trying to bring everybody along and get to the same level. So that's kind of the intro to what we've been trying to accomplish. And then just to set the table here, the care coordination system itself, as Sarah mentioned, it's internet-based system. It's ubiquitously available, I'd like to say, both on the desktop, which is in the center of the slide. You'll see a standard sort of a browser or a standard monitor with a browser fully displayed. And then just as importantly, it's available more and more away from the desktop, because our users, our workers, our members, they're not typically sitting at a desk. They're in the field. They're on their way to meeting a member. They potentially are working with other network providers at their location. So it's very, very important to get as much information, particularly actionable information, into their hands wherever they are in a very secure and compliant way. So at the bottom, you'll see that there's the iPad, so that can be standardly used on an iPad with the same presentation. And then the smartphone, both an iPhone and an Android, there's now the initial deployment of 2 applications, the alerts and the direct messaging application, capital D direct. So on the right, just to give you a sense of a big part of what's important is that all the applications are in the same space, if you will, and they operate or are integrated on 3 levels. First is the technology, so all the technology in the browser, on the iPhone, etc., works together. It might sound trivial, but it's not. The second level of integration is the data level. So the data that's not only created in the platform, but imported from the RIO, that's the health information infrastructure at the bottom left, is integrated, it's normalized, it's all the same patient across the applications, across the data sets, the same provider, that kind of thing. And then the third level, which is very, the kind of the holy grail, is process integration, where the output of one process in one application or set of functionality becomes the input to another process or set of functionality. And a simple and important example of that would be obtaining patient consent. So on the right-hand side, the third application down, you'll see is the enrollment app. That's how we either create or modify patient demographics, but also importantly establish that they are enrolled in our program or not, and that we have obtained consent or not, whether in the health home or the PPS. And then we apply that consent to specific providers. So at any one point in time, following the HIPAA rule of the minimum disclosure necessary, et cetera, that we only extend visibility to patients' information to those providers that are involved in that patient's care at that point in time. So a care management user or potentially a PPS provider user will go in with update or the patient status to enroll, obtain consent on one or more paper forms, and then record in the application that providers A, B, and C have consented this patient who is now enrolled in our PPS or enrolled in our health home, or both. Well, essentially, as soon as that person hits the save button, those organizations have access to that patient's information, alerts from the application itself or from the RIO infrastructure will start appearing in their application. They'll have access to clinical information from the RIO and the Health Information Exchange Network, along with information that's created and updated in the dashboard. And we'll see how that is done in a little bit. So that's just a simple example of how the output of one process becomes the input to another. And then as the situation changes, other providers are added to the patient's care team. Some providers are taken away for whatever reason. That's updated, and now the community that shares that patient's information and works together on that patient's care plan has changed. So on the left-hand side, the platform itself, and GSI Health can give you lots of information about it. This is a very powerful service structure for supporting the applications that you see on the right, plus providing all kinds of support for all kinds of business rules as its own data warehouse. And very importantly, it provides interoperability with any number of kinds of systems. In our case, the important one is our local RIO, HealthX, which is kind of our on-ramp to the Shiny. So the resources of the statewide Health Information Exchange Network are available to us from the RIO via electronic interface. And it's really a fairly simple approach. As we enroll and consent patients, we send that information to the RIO via message. And the RIO, once the RIO receives that information, it batches up, having done patient matching already, having collected information from many providers, batches that information up into a full longitudinal historical clinical summary, or CCD, sends it to the platform, and then the platform makes that available to users in various ways in the application. From that point forward, anytime the patient or member is admitted or discharged from an acute setting, is incarcerated or released from our jail system, or other things like that, or new clinical information shows up in the Health Information Exchange, that is transmitted to us in near real time, seconds, if you will, typically, to the platform, and the platform makes it immediately available to users through the various applications. Okay, next slide, please. This just shows one application, a care book, patient summary. We really jointly with GSI Health have designed this for clinician engagement, meaning a busy clinician in an emergency department, a primary care physician who has a 15-minute visit with the patient, or someone else who might be working with the patient and seeing them for the first time. So we're trying to provide in one simple view that for anybody who knows how to use a web browser, you can easily navigate it and do things. All the patient's demographics, their program and care team assignment, information from the care plan itself, issues, etc., information accessed via the Health Information Exchange Network, like problem lists, allergies, medications, encounters. It sort of puts it all in one easy-to-find place, and then importantly allows the users to communicate securely via direct messaging, or they can see a phone number with providers that they may want to talk to about the patient's condition. So just down on the right, just the bullets really quickly. So one page summary view. Secondly, care coordination data, again, that's generated or updated in the platform itself, is combined in an intelligent way with data from the RIO, or the Health Information Exchange Network. Third, very importantly, access is available from EHRs via single sign-on with patient context. And actually, it's also more intelligent than that, where we're about to go live with our own emergency departments, that we will notify people via an icon that important information is available in this platform outside of the ED EHR. And by a single click, that clinician will then flip to this platform, is brought to this landing page with that patient already in focus, see what they need to see, do what they need to do, and then get out. The last, of course, is, again, we talked about active links to messaging and other functionality all in one place. And to reinforce that point, again, the list of applications to the left. Next slide, please. A little more detail here on the handheld applications so far. The two are alerts and messaging. We just know from our experience that these are sort of the two things we need to get in people's hands wherever they are first. So it's the ability to read alerts, to know that their patient is presented as an emergency department at a hospital in Brooklyn, or potentially has been discharged, or potentially has been incarcerated or released from Rikers Island. And then the ability to take action by messaging securely on the right-hand side in the messaging app, some other user, some other provider, some other clinician, that this has happened, providing additional information, making arrangements for follow-up. As we talk with GSI Health, we expect that more applications will be available on these devices. Of course, they'd have to be tailored to the real estate of these devices as opposed to a full-blown browser. But again, in order, sort of order of priority, order of utility, we hope to be doing that over the next couple of years. Next slide, please, Lee. And finally, a picture of operational reports. You know, at first glance, looks like any other kind of report you can do. Graphs, tables, dashboard looks great. The important part here is that while we ourselves as a program and as a lead entity have done an enormous amount of analytics work over the last 5 to 6 years, primarily using GSI Health, with not only the data in the dashboard, care coordination data from the RIO, but also claims data from New York State, claims data from payers, other sources of information. One of the most important things, or if not the most important thing, to help frontline folks is to get that information in their hands at everyday actionable information, updated, refreshed constantly. It's one thing to give someone an operational report once a month, saying to them in a very comprehensive way, this is what happened last month with your members at your agency and elsewhere. It's a whole other thing to have that are readily available at their fingertips, so that not only, it's really simple, folks can not just see the score, but they can change the score, if you will, as it's happening. So the concept here is more and more we're trying to deploy this kind of information to our users and their organizations, so that they can see how things are going and take the appropriate action. And I think that's it for me. Lee, next slide.
Thanks, Mike. So I think we'll just wrap up with the so-called obligatory successes, challenges, and lessons learned slide. I think this journey continues, but we have learned a lot. So focusing on our hospital-based and clinic-based workflows, where we're really bringing that community-based care management into the picture. Something that we've learned for sure is that education and buy-in at both the leadership level and the frontline staff level, and honestly everywhere in between, has been absolutely essential for opening that door and realizing what those relationships can offer and making them real. And what we've seen as a result of that is that health home care management is becoming a more and more routine referral. We focused a lot in the beginning on relying on lists provided to us by the state and by managed care organizations of folks who were high utilizers or had a pattern of, actually looked like they were disconnected from primary care services, but showing up a lot in hospitals and emergency rooms, and had these diagnoses on their claims data and just deploying folks out into the streets to find them. And I think we're nearing a place where we won't have to rely on those lists nearly as much, if at all, because folks around the community, doctors' offices, hospitals, shelters, social service agencies know what health home care management is. They know how to make that referral, and they're doing it. It's a much more effective way of finding people where they are. And then beyond just the referral, I think those community-based care managers and the hospital and practice-based providers are actually much more comfortable collaborating, defining and understanding what each of their roles are, and relying on one another. And we've seen what the impact on outcomes is, and so that just continues to reinforce the value of that collaboration. And then finally, from a care management perspective, I think I started to mention this before, that one of the areas that we're continuing to try to really understand and implement in a meaningful way is how to track patients through and across the continuum of care and across our network. So developing the workflows and technology that we need to help activate patients when we think they need a higher level of care, and to allow them to step safely back down into a less intensive mode once they've stabilized. So sort of flexing care management on a more person-centered level. In other words, someone may need a health home care manager for a period of time, maybe 3 months, maybe a year, but not forever. And when they're ready to sort of graduate or step down and be managed at the level of their primary care practice, for example, we would love to be able to know that there's something in place to say, oh, a lab value just came back that indicates something's going wrong in the management of a specific disease. Or looking to another part of the network, someone registered for a stay in a shelter bed last night. Something must not be right, and be able to really quickly activate and deploy people to find out what's going on, make adjustments, and perhaps enter into a period of more intense management while a crisis gets resolved. So I think that's where we're looking towards in the future, and continue to explore all of these opportunities. So thank you very much.
And thank you, Sarah and Mike. Really appreciate your contribution and your sharing your expertise. I want to remind the audience that we will have a Q&A session at the end. I'm going to give some brief remarks as well. And so if you have a burning question for Sarah and or Mike, please put it into the questions section, and we will get to as many of those questions that are submitted as possible. And also, as you can see, the contact information for Sarah and Mike are presented on the webinar screen now. So I'm going to just offer up a little bit of commentary about this activity around creating a network, and I'm going to step back a little bit from what we've discussing so far, but I think follow the same themes. So before I really start that set of comments, I wanted to give everyone a sense of the context by which we're speaking. And so GSI Health has a population health management solution that incorporates care coordination tools as well as analysis tools so that they can better the delivery of care for populations and for patients. And we believe that we should have a close coupling of those kinds of tools because the insights that one gains from analysis needs to be translated into the care coordination context for improvement's sake, and vice versa. The information that is thrown off from the delivery of care needs to quickly and directly impact the analysis that is done. And so we have been giving webinars, and in this particular series, this is the second message. And the first message that we had, we discussed the idea of how to get started with value-based programs. We focused on DSRIP as a case study, but really talked about a number of principles that apply to all value-based programs. And so if you participated in that webinar, you may recognize that we essentially drew out a map for you to reach the treasure of value-based outcomes that are good and solid and improving. And we talked about going through a number of different steps to get there that covered data and analytics and changing things, as well as technology and population determinations, et cetera. I'm not going to rehash all of what we discussed in the previous webinar, but we certainly invite you to access that webinar on our website if you have interest. And I'm going to focus in on just 3 of those areas that we talked about last time, and as it pertains to this idea of building a network. The first one I want to talk about is the workflow and how that network of providers of various kinds and multiple disciplines actually work together. I want to talk a little bit about the technology, because the premise that we're operating underneath this creation of value that comes from banding together as a network of providers is actually undergirded by a solid technology platform that enables all of these interactions to take place in a useful way and an efficient way that actually delivers value to the population. And then I want to talk a little bit about the coalition, or building a network itself. And so in the previous webinar, we talked about those in sort of reverse order. We talked about building coalitions and then technology choices and the workflow. I think I want to reverse that order, because I want to culminate with some thoughts about what it takes, or what you should be doing to plan around building a coalition. We also talked in that webinar about the treasure is not just at the end of the rainbow or at the end of the map where X marks the spot, but really there is a lot to be gained along the way. And we laid out 5 different tenets of population health management that we thought were important for not just the development of the program, but ultimately for the improvement in efficacy of the program. And so there's a first set, transparency, control, and measurement, which I'm calling enablers. And transparency, we mean this idea of sharing information, breaking up silos. Everyone understands what the others are doing, and being able to facilitate that through mechanisms like interoperability, et cetera. By control, it's the idea of having some sort of governance and ability to manage the work that people are doing to impact these populations. And so that may be forming care teams, that may be having supervisory hierarchies that do follow-up and other kinds of workflow. That may mean the paradigm by which different organizations cooperate with one another. And then finally, measurement is another enabler, because it allows us to see what we're actually doing and see if it's meeting the goals and expectations that we've set out for ourselves. And so this set of enablers are things that can improve along the way and deliver value to both the program and to the populations as you make your way and evolve toward better outcomes. Similarly, there's a set of these tenets that go toward transformation. So ultimately, the reason that we measure and do these kinds of programs like Health Home and DSRIP in the way that we've been doing them and talking about them is that we want to ultimately transform the care delivery model. And so that, again, is dependent upon measurement, but also being able to analyze and create solutions so that we can do better than we've done in the past. And that process of doing some detailed analysis and being able to project the impact of doing certain kinds of changes in our processes and our care delivery to build new solutions is sort of the iterative step that will make us successful in moving toward that treasure. And then, of course, if we make changes, then we have to be able to manage those changes and make sure that they are effectively implemented and deliver the value that we want. And so we talked about gaining all of those different jewels along the way. So with that, I want to just talk again about those 3 areas that were on the map and talk about them in the context of building out a network. First, I want to talk a little bit about this idea of workflow. So when we talk about population health management, even though we're often sidetracked by the technical discussion about how to connect partners in a technology way, my EMR or my HIE or my ED system or whatever it may be needs to talk to some other set of systems. But really, it's all about integrating people. We're at the end of the day trying to create a team that can work together seamlessly and effectively and do that and bring value to their common set of patients. And so if we think about trying to integrate the people and not just the technology, it means that we can look forward to having systems in place that work with all the different partners that have to participate. And it's already been discussed by Sarah and Mike that this is really a diverse set of partners, and so the idea of being very disruptive in order to perform activities associated with 1 or 2 programs isn't so palatable when trying to build the network. So our focus, our belief is that we should all try to co-opt as many workflow elements as possible from across all the participants so that they can have the minimal impact on the way that work is done effectively in today's context, but at the same time can contribute in a meaningful way toward this expanding context around population health management. And so getting that straight up front and trying to understand what is important to each partner and each participant really will help you rather than trying to solely figure that out along the way, rushing to put things in place that haven't gotten full buy-in or full vetting in terms of how they'll actually work. And that is going to give you a degree of control of your program so that you can steer it in the direction that you want when you've fought those battles over workflow and really have coalesced on some models that people have buy-in with. And so when we talk about that, we presented a couple of paradigms to the extent that the coordinated care plan is sort of a central rallying point where one can not only document things that have happened in the past, but also document things that are planned and will happen in the future or are tasks for people to accomplish. That content for the coordinated care plan may come from evidence-based protocols. It may be best practices that are a part of the local system. It may be organically assembled by the expertise of the users and care managers who are involved at the time, or more likely some blend of all of those things. But there's this idea of there's a single point where all of that input comes together, and in the model that we think is successful, it comes around this coordinated care plan. But the way that the coordinated care plan is constructed can happen in a number of ways. I'll talk about 2 here. One is this idea of having distributed documentation. So to the extent that there's a documentation activity that goes toward creating a care plan, could be that the care planning mechanism is available to everyone who is on a care team, everyone in the network, and they all are equally contributing to that documentation process. And that would be tantamount to having a population health management system that enables users of all the different disciplines and types, and people are actually contributing their specific expertise directly or by proxy, but having hands-on access and influence on the care plan. That model can work, and it's one that I think is probably the ideal model. The issue becomes, do all of these different care providers have the ability, the time, the wherewithal, et cetera, to keep up with the process to actually contribute toward a care plan in that collaborative fashion? And so there may also be room for a model where it's sort of a centralized documentation activity where a care manager or some other designated role plays the quarterback and really is the one who constructs the coordinated care plan with input from all of those different partners. And so in that case, a bigger emphasis on standardized clinical messaging, protocols for how the information is going to make it to the centralized documentation role or setup roles becomes more paramount. What I think we've seen is that there's really a blending of these two approaches that tends to happen across our customer base. And so the question is, given that there's likely to be multiple models for touching one centralized, hopefully standardized mechanism that's going to contribute toward improvement, how is it that you actually can account for that variation and still have something that's rational in the end? One part of that is trying to settle on technology that will aid that process. And this is where a number of programs really start to have some first degrees of difficulty. When we ran the webinar last month, we took a poll of the audience, and about a third of the participants said that they have trouble with technology and data and integration, and that was sort of their biggest obstacle to moving forward as expeditiously as they wanted to in their value-based program. And another third said that it was the forming of this network. And really, forming this network and the technology that supports it is a big topic, because everyone comes to the table with things that they've already invested in, ways that they already do things, electronic health records that are already prevalent, health information exchanges that are a part of the ecosystem, et cetera. So our view is that's great, and as I said, we should try to leverage all of the things that are in the ecosystem rather than supplanting and replacing things. But we should also recognize that this population health management activity is something unto itself. It's not just an augmentation of charting. It's not just an augmentation of analytics. It's not just an augmentation of the HIE, which is how it's sometimes addressed. And if you allow in your network that you're trying to measure and actually improve too much bring your own technology, then those thousand flowers blooming don't have the same efficiency and efficacy that you likely want for this unified program. So keeping the population health management as its own idea and objective when trying to settle on some technology will pay benefits. So with that, the building of a coalition or building of a network is has these considerations that I've talked about, but also it's the idea that we're really a team. At the end of the day, we're trying not to just have names on paper of people who've agreed to some sort of program that will compensate us in a particular way, but that we are bought into this idea of we can all bring something to the table to improve the outcomes of our respective organizations, of our respective populations that we manage, the patients that we all care about, as well as gain the efficiencies that will win those different kinds of incentives and or a gain share in a risk situation that we're looking for. So rather than having a sign up, raise your hand paradigm, we've seen that it's effective when there's a partnership model, much like Sarah was talking about, where the formation of committees, people can have the opportunity to make decisions about how things are going to happen so that they have ownership. And if you're able to do that, you gain both transparency and control before you have to make some of those more specific decisions that I talked about along the lines of workflow and technology. Getting the buy-in around how we're going to operate and how we're a team striving toward a common goal goes a long way toward overcoming some of those hurdles that we've seen in our customer base as they try to put new dimensions of care in place and they meet less resistance. And so your network of partners have to be more than just Rolodex entries. They really need to be partners in a broad sense. But when you're forming that network, it's important to understand what the network means. So there's often a lead organization or a convening organization who brings all of the partners together, as has happened with the Brooklyn Health Home and Community Care of Brooklyn for health homes and district respectively. But as you go along and try to recruit partners, you'll have partners who are of various stripes. One is you may have partners who are part of the same parent organization, so there's some administrative controls that are already in place. And there are other partners who are part of different organizations, but they may have some direct financial relationship, either being part of the program or through some other means that compels them to participate broadly. There may not be the direct financial relationship from the program, but there may be some other leverage point like referral networks or other kinds of relationship incentives that compel people to participate. And then there are likely, as we see often in New York, different organizations who have no specific incentive, but because patients can go wherever they want, these other kinds of providers may figure into the ultimate delivery of care to a patient, even though they may not be formally a part of the team. So the thing to take away is you're likely to have different partners in forming this network who have different points of view about what is being done and what their role is in that. And then when you're trying to measure the efficacy of your own program, you should draw a box around the ones where you actually have governance over them. So including people who are going to contribute care, but they are not subject to the governance that allow you to make changes and to improve, is probably going to be counterproductive to your goals of improving your measurements. And so recognizing who your team members are, and by team members here, I'm saying partners who are actually going to not just be consumers of what your network is providing, but also contributors to it in a specific way and beholden to you for changing. And then understand that there will also be some service contributors who are a part of the overall delivery of care, but they may or may not be appropriate to include in your measurement around how that network is actually performing. That same idea goes for other networks. So in New York in particular, there are lots of different coalitions now that are forming around healthcare, a health home, around district and other things, and you're starting to get different networks that are overlapping and or need to cooperate in some way because they're touching the same sets of patients. So our view is that you still need to have some network boundary that allows you to normalize the care that's appropriate for your program and for your populations of interest. But you can recognize that there are other networks that share the same patients or overlap those populations and facilitate data exchange across them. The community-wide reels are very good at facilitating this network-to-network paradigm where the networks are defined around programs. So the same idea of having a boundary with a network of team members, and then other networks can be service contributors. When you do your measurement of how well you're doing, you want to make sure that you're concerned with your network and not just every contributor of services. Otherwise, you may skew your results and not be able to improve in the way that you're most concerned. And so when we think about trying to now draw that box around who is a team member and who isn't, the question really becomes, how is it that we prepare for having success in value-based care, by catering to what those team members need? Well, first thing is we have to remember that there are different flavors of team members who have different sets of circumstances. So we may have a blend of some who are able to participate in a distributed documentation paradigm and are users of your infrastructure directly. There are some who may be more arm's length and are reliant upon some accommodation of a centralized documentation point. For those that are able to participate, they may be able to fully use the platform that's being brought forward, and that has a number of different advantages. But there are also incidents that we see in our customer base where there's sort of a divided use of the platform. There may be some activities that are undertaken on the population health management system and other activities that are documented and undertaken in other systems. And either there may be at times duplication of documentation or interoperability that tries to overcome that, or an agreement and paradigm about what is the source of truth when it comes to particular pieces of information. You're likely to see all of these different kinds of circumstances as you build this, and that's why it will be important to really think about what kind of interoperability will exist among all of those systems that are used by all the different partners, and to make sure that it's viewed, the interoperability plan is viewed from a workflow efficiency point of view, so that there isn't just an acknowledgement of we need to connect here, here, and here, but it's really an understanding that we're really trying to achieve this kind of workflow, and therefore that requires certain interoperability to be in place. Or if we cannot establish it in the way that we ultimately want, we want to be sure that we know that, and we can build our processes to overcome that deficit. And so when you then are planning, you have to think about the members of the network and try to plan for the particular paradigm that they're going to be using to participate in this network from a workflow and coalition standpoint. And so that's really where I want to end up by talking about some of the things that you may want to keep in mind. And so when you have partners who are going to fully utilize your population health management platform, it means that you have a controlled source of truth for measurement and for analysis and reporting and improvement. There's not a loss of information as you translate from one system to another. The analytics and the reporting can be more readily done in a timely fashion without semantic disconnects where one thing was intended and another thing was documented. The same paradigm can be rolled out and trained for all users of that platform. You can have this divided platform where there are multiple systems that are ultimately the source of truth for different parts of information, and that has implications versus if you contrast it with the full platform use. The information that is housed in a foreign system now has another set of processes that have to be at least accounted for in how you're going to ultimately do your measurement and your improvement activities, given that there's information that is resident somewhere else. And then there are some systems that will, or some partners that will only refer to your platform, but not really contribute directly. So there may be single sign-on, as Mike was talking about, or other kinds of read-only access. And so there may be information that is being captured in these other modes that may be obscured from the governors of the network as they go forward and try to evaluate. So planning for all of these circumstances is important, and the further that you go to the right, obviously there are more planning activities that need to happen. So if we look at some of the things that you may want to consider and use the red boxes that will pop up here as planning work that you want. When we're talking about in the full platform use, obviously the designing of the use of the platform and how you're going to train and make people do that in a consistent fashion, how the documentation, whether it's retrospective or prospective documentation of events that have happened or that you plan to do. How does all of that work, and how do all of your users actually take advantage of that? And there are a number of things that Sarah touched on how you might do that. But if you're going to also have some divided use of the platform where there are other systems that are controlling portions of the information picture, there are another set of things that you may want to account for. You want to make sure that there's a specification of the primary and secondary sources of truth wherever the data models overlap across systems. And so if we're going to document care plans for one kind of condition in an electronic health record and another kind of condition in your population health management system, and it's on the same patient who may have other pieces of information that attend both, what is the source of truth and how do you reconcile those things? How is that information getting reconciled? So talking about where the source of truth lies is a part of your planning process as you build out your network. Secondly, you may have to specify a scheme for system cross-reference. It may be that you're trying to avoid duplicate documentation, and so you want one system to point or refer to another. Whatever that scheme might be has to be a part of your planning so that, again, the workflow will not be disruptive and everyone understands what they're supposed to do. And then you should always have some process that you're prescribing when you know that there's going to be separate sources of truth on how you're going to audit your information and reconcile whenever it's needed, because that will occur. Things will happen and get out of sync, and there needs to be an accounting for it as you're doing your planning, as you're building your coalition, so that in and of itself becomes a part of the workflow. And then when there is more of an arm's length relationship, if you allow members of your coalition to participate in that way, then there will be an obscured source of truth, and there are another set of activities that you would need to do in addition to the ones I've already discussed. You need to specify the way that you will discover or people will report the activities that are going on that are not documented in your platform. And so understanding how it is that you'll find out about what these more arm's length participants are doing and how that will make it into the information that's going to be important for analysis and improvement is something that shouldn't be left to the end or be discovered when you stumble upon it. You need to allocate resources for some delegated documentation. If there are going to be consumers of information who are doing activities you care about, there should be an accommodation for how those activities are actually going to get documented, who's going to do it, and that impacts the delivery of the coalition building. Specify a team member cross-system procedures. So if there are multiple systems involved and you may have some single sign-on where, as Mike was describing, there's some indicator of information that's resonant in another system. Whenever you're bringing on partners like that, that training of the workflow that is unique to the interaction or lack of interaction of those two systems has to be a part of your overall program's effort. And that could really, if you allow too many of those arm's length relationships, that could really get unwieldy because you have a number of different training and procedural things that have to be customized for different partners. And you have to account for the fact that as you move toward the right in this diagram, there's going to be a bigger and bigger skew in your reporting that comes from incomplete data and inconsistent data because of the translation that has to happen as you get further away from your centralized system. And so the main point from this slide is to say we want to make sure that we plan on the effect of building a network on workflow and how to make all the network participants as efficient as possible. And so in summary, I'll just leave it there to say working on a workflow, working on your technology platform that supports that workflow, and ultimately feeding what you know is going to come down the pipe from those different perspectives into the discussions that you have around coalition is what's going to make you successful. So I'll stop there because I know that we're very close to time, and I know that we're at least a few questions that have come through. So I'll turn it over to Sean. Maybe we can get in a question or two before we have to end at our time.
Thanks, Lee. Thanks, Mike. Thanks, Sarah. We've got a few questions from our audience. One of them, or one theme that seems to permeate a few of them, is about interoperability with various systems. Specifically, is it possible to exchange care plans from the GSI Health platform with other systems like RIOs, like EHRs, and then the use of claims data as another source? So maybe Lee, you might want to start there, and then Mike and Sarah can chime in.
Sure. The short answer is yes, but I would say that the standards that are involved in that kind of exchange are fairly immature or nascent, and so there are some though that enable that kind of exchange, and we GSI Health have the ability to do those kinds of exchanges, but again, finding the other side that can actually do them is maybe hard because it's very early on. I don't know if Mike has something to add to that.
Yeah, that's correct. Certainly, as far as care plans and structured care plans, and for sure. However, we do. GSI Health does obviously support current interoperability standards around standard IHE and HL7 messages. That's how we communicate with the RIO. It's also, as I saw one question, how we enable single sign-on with DED. So basically, we're in that example, we're essentially an ADT message is sent to GSI Health. Is run against a set of matching and rules, matching engine and rules to determine, do we know the patient? Is the patient a member of our program? Do we have consent? Does value-added information exist? And that says, and then it sends an HL7 message back to Maimonides, basically saying light up the icon or don't. And Maimonides internally distributes it to the correct EHR. So that's kind of a special case. In the RIO's case, we send a variety of, GSI Health, we send a variety of messages to the RIO. Patient demographics are PICS messages, XACML for consent. We use the HIEM format for care teams and enrollment. And what the RIO sends back to us, they send, of course, a CCD, a longitudinal clinical summary in the standard format, and they send back these alerts, these clinical event notifications, admit and discharge from acute settings, and incarceration and release from the city jail. Again, they send to us using the HIEM structure. So we can basically, GSI Health has a technical capability really to play with anyone. They and we prefer standards-based. Sometimes we make an exception for a special high-value case and do something custom. But that's kind of where we are. I know GSI Health and we are working in statewide and national initiatives around defining the structured care plan, both the current draft standard for trial use, which is currently in play, plus an advanced version that addresses more requirements. So when other folks are ready to, as Lee often says, pick up the phone on their end, we'll be able to work with them a structured care plan exchange.
So I think we've reached our time allotment and would like to especially thank our participants today from Maimonides Medical Center and the Central Services Organization and the Brooklyn Health Home, Sarah Kaplan-Levinson and Michael Carberry, and from GSI Health, Lee Jones. For those of you that did ask questions that we didn't get to, we'll be happy to follow up offline. Also, as I mentioned earlier, you'll receive a link to the recording of this event. In addition, there are others on the GSI Health calendar that will continue to present as we focus on population health management initiatives for both today, tomorrow, and into the future. So please keep an eye on gsihealth.com, our website, continue to publish updates on that scheduling. I thank you for your time today and hope you all have found this a really valuable and informative session, and we hope to speak with many of you in the future. Thank you, Lee. Thank you, Mike. Thank you, Sarah. And thank you all for attending.